How is it that the wealthiest country in the world has such a screwed up healthcare system? After 35 years in the healthcare industry, I decided to retire and share my secrets with you. I'm Chuck Melindy, and this is Disruptive Dialogue. Hey everybody, Chuck Melindy with Disruptive Dialogue. Hope you're doing well today. Very excited for the guest that I have. Her name is Roaya Tyson.
It is.
Roaya is the Chief Executive Officer for Gracepoint Behavioral Health, soon to be known as Ibis Healthcare. They are in the final stages of a merger/combination. She's going to share some of that with us, but before she does, I want to tell you a little bit about her. So what I love about Roaya, besides her incredible
Everything?
Besides everything. Oh, you can tell we already know each other. By the way, I'm her chairman of the board.
Yeah,
so
he's my board chair.
She kind of does work for me.
I do.
But actually,
he works for me too.
Just like with my wife and my daughters, I actually work for them.
Mm-hmm.
What do they call that? Servant leadership?
That's exactly right.
Servant leadership. That's what we do. Men, all you out there. So, all seriousness, Roaya, I love her career path. So often we see executives and they hop from job to job, and there's nothing wrong with that. But it's special when you start, I don't want to say at the bottom, but you start at the beginning and
it was the bottom.
Social worker, work your way up to be the CEO. So quick snapshot, 2025, Roaya started with Gracepoint in 2002, managing their child welfare program. In 2008, she was promoted to the Chief Operating Officer. She oversaw numerous clinics, their outpatient care, community services, managed care, primary health. She was responsible for ensuring the successful operation of 2 crisis stabilization units with 74 beds, a secured 28-bed forensic unit, which is people coming out of the
That's right.
Justice system.
That's correct.
And so that's what forensic unit is. It's not what you see on TV, the forensics.
Right. That's right.
Medication management clinics and community-based programs for children and adults, as well as the integrated primary care center. All of these programs together have made Gracepoint one of the largest community behavioral health providers in the state of Florida. She has more than 25 years of clinical and managerial experience and serves on numerous advisory boards. Roaya, thank you for joining us today.
Well, thank you for having me.
I am super excited. As you know, in our country, there's a couple of epidemics going on. Mm-hmm. You have the GLP-1s, so everyone's talking about obesity, but especially with the pandemic, we did see depression and anxiety and mental health or mental illness really bubble up. And we're definitely going to get into that. But my viewers, I don't know how many of there are. Hopefully we're growing. My viewers are used to me saying I'm semi-retired. So I try to have fun and have a cocktail. We have water with us right now.
We do.
Because we met right before this. And Roaya had me drink her favorite drink, which is some kind of snake thing.
Well, it's one of my favorite drinks.
And what is that?
It's actually called a water moccasin.
A water moccasin?
Yes, and I have to give the credit to my husband who introduced me to the water moccasin.
Is that Mike Tyson?
No, that's Tony Tyson.
Oh, okay.
But they're related some way or another.
Okay.
Or the Tyson fortune of the chicken. So we would go to Hattrick's, and they mastered the water moccasin. It's kind of a shot.
Okay.
But we were being a little more civilized, and we had it with ice.
So share with the audience, what is a moccasin?
It is a shot of Crown, a shot of peach schnapps, and a splash of sour. So it goes down very nicely.
Very nicely.
Yes.
And after you've had too many, I think you told me
I did. Yes, I did.
There's a
You're make
visual cue.
Yes, there is. So when the bartender gets to know you, as they did at Hattrick's, you would just kind of do one of these and then like this, and then they would know that the whole table needs another round.
Yeah.
Yeah.
So it's kind of like
very efficient.
Kind of like a little
That's what CEOs do. They become efficient.
Yes. My kind of CEO. Okay. So, one thing I do like to do when we are doing our programs is let the audience get to know you a little bit.
Sure.
I gave them your history, but if you wouldn't mind sharing with us, how'd you get into this field? What inspired you, motivated you? What was it that made you get into this field?
That's a good question. I actually fell into it. My career path initially was going to be in law, but I had addiction in my family. So I was raised in a house with alcoholism. And so I wanted to fix that. And so then you go into the codependency route, which is just basically caretaking everybody. And I didn't get very successful at that. So I figure if I can't save my family, maybe I can save everybody else's. So I said, okay, well, let me check out the psych route and see what that looks like when I got to college. And that's kind of where I fell into.
Well, that's awesome. And a lot of people are blessed that you
Oh, thanks.
made that decision.
Yeah, thank you.
So let's talk about mental health because everyone is impacted.
Mm-hmm.
I love to tell the story that when I first got involved in behavioral health, as we used to call it in the industry, that I went to a meeting and the lady that got up there and spoke basically said, would everybody in the room raise their hand if you have
It's a great exercise.
Yeah, it's a great exercise. If someone in your immediate family has been touched by mental health, and people raise their hand. And then she says, okay, anyone in your extended family or immediate family, please raise your hand. And a lot more people. And then she finished it with anybody in your immediate family, your extended family, or a good friend been touched. There's almost never a hand not up. It impacts all of us.
That's right.
And what'd you say when we were having our water moccasin? You said it's equal opportunity of.
It's an equal opportunity destroyer, can be.
Yeah.
Actually.
Yeah.
Of all the years that I've been going through this, there isn't a social class or a race or ethnicity or a religion that this hasn't affected. So it really is an equal opportunity offender.
Yeah, and we joke about it a little bit, but as we all know, I mean, this is what we do, and we're both heavily involved in this, and it's a very serious topic.
It is.
But sometimes you have to laugh not to cry. So a lot of people that listen to the podcast, they're, like my kids' age and in their mid-20s and stuff like that. You've been doing this for a while now.
What are you trying to say?
I'm trying to say you're younger than me.
Okay, thank you.
But you've been doing this a while now, since you got out of college.
Yeah.
Give everybody a little bit of a landscape of how the behavioral health field and mental illness or mental health in our country has evolved. Not just the stigma piece, but the treatment piece, everything. Give everybody like a quick evolution of the last 3 decades.
Oh, wow. Okay, well, when I started out, just to give you an example, I started out working in addictions, of course, because I was going to save everybody, remember?
Right.
So the only medication that we had to work with discouraging alcohol consumption was something called antabuse, which is nothing more than a medication that when you take it, if you drink on it, you get sick. So the whole point is you drink, you take, you get sick, you drink, you take, you get sick. So eventually I'm going to just stop drinking as opposed to stop taking the meds. That's all we had.
Okay.
And AA, which is, I can't speak enough about the 12-step program, but that's just one tool in the toolbox. So as time progressed, so did addiction and so really did mental health. So now you have, I'm going to fast forward several decades, you have social media and you got kids that are buried headfirst in their phones. You have cyberbullying, all that stuff that, I'm going to compare myself to the Photoshop and I don't look as thin and whatever it is. And so they're becoming more and more withdrawn. And addiction is becoming more and more in depth. You got opioid addiction.
Fentanyl,
all that. And they're so much more potent. And I think we've risen to the occasion pretty well, but we have so much farther to go.
So would you say, one of the things that I look at is prevalence.
Yeah.
Do you think it's more prevalent today or just that with the tools that we have and the understanding that it's just easier to diagnose?
I'd say both. So I did a little research and the CDC says back in 21, they did this little research that 1 in 5 people in the United States self-report as having a mental illness. And that could be something like a depression or anxiety. It doesn't have to be some kind of psychotic disorder. So I think it's more people are willing to acknowledge because people are talking about it. And I think there's more access for people to help them identify it, if that makes sense.
Absolutely.
Yeah.
Yeah. One of the other things that I'm curious about,
Yeah.
and I think it would be helpful for everyone to understand.
Mhm.
So people think about if they have, if there's mental illness and they need to be Baker acted or they need to be admitted to a facility.
Mm.
So could you share like what the facilities used to look like?
Oh my. Yeah.
And remember, for the old people out there, that One Flew Over the Cuckoo's Nest with,
Yeah.
what was it, Jack
Jack
Nicholson?
Nicholson.
Oh, yeah.
That was
That was
great.
really
It was a
interesting.
great movie.
And we don't have those anymore, my understanding. But, you have hospitals, you have community mental health centers, you have QHCs, things like that. So kind of give us an idea of each one of those and where we're at.
So we do have state hospitals still. There's
Okay.
just much fewer of them
Okay.
because I think it was in the Kennedy area. I wasn't really practicing then, believe it or not. So, but I believe that was the era where they started to say, okay, we're going to close down a lot of these One Flew Over the Cuckoo's Nest type facilities and
Right.
put it back into the community. But there's still a couple for the very deep end folks that can't be stabilized in the community. And for those that don't know what a Baker Act is, it's just the involuntary examination. And you can hold people up to 72 hours to do that. So we are able to do that in the community. So hopefully, the family comes and the friends come and they have like a support system around them as opposed to going all the way to Chattahoochee or, wherever
Right.
and have to, travel 6 hours and then just forget about them.
Okay.
That's kind of how it was looking.
Right. And so like a community mental health center,
Yeah.
like maybe explain to everyone what that looks like
Sure.
today, how that operates.
So a community mental health center now really looks so much different than, I'll just use our place, for example, so much different than what it did in the 80s and 90s.
Okay.
And so the goal is to make it look like a place that anybody would want to come to. So it looks like the hoopsie poopsie neuro spas, and it looks like something you would see in a large hospital system. But instead, it is funded in part by the state. It's funded by self-pays. We don't turn anybody away. But just because we don't turn anybody away, we don't want it to look like it's something less than what everybody else goes to.
Right.
And that's kind of the essence of what a community agency is. It's just behavioral health and primary care. It's not mixed with a bunch of other stuff so that the service is diluted.
Yeah. So as being part of your board, part of what the board needs to do is half the board has to be a patient at your facility.
That's exactly right.
And I will tell you, as a patient at Gracepoint, it's awesome. I mean, clean, everyone's professional. You would not know that you are at, to your point, a hoopsie doopsie.
Yeah, hoopsie poopsie
Medical clinic that I think that water moccasins hitting.
Yeah, good.
Or somewhere that's less low income area that somewhat dilapidated and dirty and run down. It doesn't
we're
look
not doing
like
that.
that.
We're not doing that. So the whole point is when you come in, Chuck, whether they don't know if you're the board chair or not, they just know you that you're Chuck and you're coming in and they're going to take care of you. And that's really the goal. And
I think a really cool thing that you brought up that, we may be jumping a little bit ahead here, but you touched on it, it was both behavioral health and primary care. And that gets to the integrated services, which has not always been the case.
No.
And maybe run everyone through that a little bit.
Okay. Well, when I first started, I started to realize that, well, first of all, I didn't realize it was research that demonstrated that people that have a mental illness, their mortality rate is higher, which means they die sooner than the general population by about 10 years.
Oh, yeah.
So they're so busy focusing on their mental health or not, or being ravaged by addiction or whatever the situation is, that they're not taking care of their high blood pressure or their diabetes or whatever it is. So the idea was, why don't we have a family practice here that can serve people with and without mental illness? But if they come in with a mental illness, wow, how cool would it be that we had the psychiatrist talk to the primary care physician and make sure that the meds work together, they don't work against one another, that one doesn't cause being obesity or one doesn't cause depression, and they can work and actually have a treatment plan that takes care of the whole person.
Yep.
And so that's kind of the genesis of that.
And I would think that, a big thing that we talk about a lot is stigma.
Yeah.
And like at the end of the day, people don't want to be considered, as people say, crazy or
That's
whatever. Right. Unfortunately, in the past, and I do believe this not as a clinician, but just as a human being,
right,
that in the past there was a huge stigma to that. you could break your arm, you could have congestive heart failure, you could have a stroke, and people look at you and feel bad, and they don't think you're weak or you
Right.
did anything wrong.
Right.
But it used to be like, if you had anxiety or you had different disorders mentally, they looked at you like something's wrong.
Something's wrong with you.
And
Yep.
there is no difference. Physical and
None.
mental health, both are illnesses, both are sicknesses, both should be treated. And it has been a journey, and we are not there yet.
We aren't.
But let me ask you, do you think it's gotten better?
I do. I do think it's gotten better because there's more forums like this and social media where people are talking about it. And then you realize how many people you know, including yourself, that may have a depressive episode or get anxious chronically about something. And we're starting to learn that there's physical origins to some of these things. There's neurological origins. And so it should be treated the same as if you had cancer or anything else. There's a genetic predisposition, means if mama had it and daddy had it, I got a better chance of having it. And so that's what we're facing. And we all have to realize that it doesn't mean you're less than.
Yeah, absolutely. And what's interesting is, as you mentioned, the physical piece. So in my old role with drug manufacturer, I dealt with like 9 different disease states, whether it be cancer or it was immunotherapies or mental health. And usually if somebody had, and the data shows this, if you have rheumatoid arthritis, if you have cancer, et cetera, you also have a higher chance of having some form of depression.
How could you not?
Absolutely. You're like, why me?
Right.
All these things. And on the flip side, if you're depressed, you're not going to exercise as much.
That's right.
You're not going to probably eat as healthy.
That's right.
And so that exacerbates
and potentially self-medicate with
self-medicate
stuff.
Absolutely.
With stuff.
Drugs, alcohol,
whatever.
You name it.
Water moccasins, whatever.
Water moccasins. Yeah. So one thing that I hear a lot of when I was out there working in this field as a manufacturer was the lack of providers. And on your board, I know we talk all the time. Has it gotten worse or better, or is there no difference than it was 20, 30 years ago?
It's terrible. So what I can tell you is there were less providers back in the day when I first started. I won't tell you exactly what day that was. And there's more providers now, but the competition for those providers is fierce. So you have, all the...
When you say the competition
for the workforce, competition for therapists. So you have somebody that is offered $100,000 a year to work in their pajamas at home doing virtual health for a for-profit, and you make your own schedule, versus coming into my place that's a community agency that doesn't have the margins that they do, making $55,000, you got to come to work. What do you think they're going to pick?
Right.
I mean, they're not as always as mission-based as I am to say, okay, this is where my heart is. It's more like this is where I can get my new suit and my new car. And, and I don't begrudge people that.
Sure.
But surely there must be some population out there that still wants to work with this group at this rate, I would hope.
Well, I look at it multifaceted, and you keep me honest here.
Always.
First off, yes, I know.
It's a full-time job.
It's a mutual thing.
No doubt.
So I think there's obviously more people in the world.
Sure.
More people in our country.
Yep.
There might be more providers, but I don't think proportionally that there's as many providers per patient as there used to be.
You're probably right. But the ones that are there are going...
Right.
Yes.
Yeah. Now, that being said, to the second point, more people are being diagnosed. So I think, yes, there's more people, but there's more people realizing what mental illness is and the different forms, whether it's anxiety or eating disorders or depression, but also more willing to come forward because the stigma is going down.
That's true.
And to the last point that you said is providers in mental health, it hasn't gotten to the point yet where they are being compensated like providers who take care of physical ailments.
100% true.
And so if you're a kid in training, residency, fellowship, med school, you say, okay, I can go be a surgeon and make whatever, $500,000, or even be a PCP and make $250,000, but I'm going to go be a therapist and make 75 to 125. We have to put money behind that profession if we want to have more.
Well, I can take it one step further. So yes, if I was a physical therapist, I would probably get reimbursed significantly more per hour than if I was a mental health therapist. There's no question about that, which is
Crazy.
absolutely crazy.
No offense to physical therapists out there,
But, you know,
but it's a lot more complicated to get inside someone's head.
Someone going in and going through the ED every, couple of weeks because they're paralyzed with fear, it's going to cost the ED a lot of money to run all kinds of tests, which they were obligated to do. But the other part about that is when we're talking about community agencies versus private sector, the same psychiatrist, let's just say, Dr. Smith. Dr. Smith can work in private practice and get reimbursed. I'm just going to throw out a number, $200 an hour.
Okay.
That same psychiatrist can go work for a community agency, provide the same medication under the same circumstance and get reimbursed half that. Now you tell me how that's fair.
No, it's not fair.
It's insanity. So why would we want to decimate a community agency when they are so valuable? I don't understand.
Let's talk about that for a second.
All right.
So help people understand, I'll throw a couple things out there real quick. So you always hear about these safety net providers, the provider of last resort.
Yeah.
And with all due respect, and not all hospitals are the same,
Mm-hmm.
but not all hospitals are safety net providers.
100%.
And not all hospitals accept everybody. Community mental health centers do.
Right.
I know that at your organization, there's a sliding fee scale.
There is.
I know that if someone can't pay for their services, you don't put a collection agency after them.
They're seen anyway, regardless.
No matter what.
Right.
And there are very few of those in communities.
That's true.
I don't know, is there an answer to it? Is it just we need to bring awareness to, I think, before you answer that question, I do believe there was a watershed moment that gives an opportunity for mental health with the pandemic. Because when I was in my old job and I was involved with advocacy and legislation, the legislators after the pandemic were a lot more interested and wanted to be more helpful with mental health issues because we saw an interesting dynamic. Everybody had to stay home.
Yeah, that's true.
So these legislators, and nothing wrong with legislators. Look, they're just like any of us. They're trying to do the best job they can.
Of course, with
the
what they know.
knowledge they have,
right?
And the experience they have. But when you're at home and everybody's cooped up and you see your kids' anxiety, you see them on social media, you see the cyberbullying, you see you and your spouse having issues, you start to realize, whoa, wait a minute, there is something going on here. And I truly do believe both on the state and federal level, there is more attention being paid to it. We're not going to talk about mental health parity today because that's a big thing. I think we're going to have a part 2 for that.
Okay.
But I want to stay on this piece.
Sure.
But what are your thoughts around that? Do you agree with that or do you back and forth?
Yeah, I do. I mean, I think what you said was I think they're doing the best they can with what they know. But there's a lot of people coming at them for a lot of different things. And so when you have a community agency that is trying to get the attention of a legislator versus a hospital system that has 15 hospitals throughout the state of Florida, guess who they're going to pay attention to? Right. I mean, it's human nature.
Sure.
I don't fault them for it. It's just how things go. So I think that we do the best we can with what we have, and they do the best they can with what they know.
So I think, moving on from the whole community mental health center, I think people need to do a little bit of research and figure out what those are. During a mental health crisis, what would you tell everyone? Because that's a scary moment when a friend or a spouse or a child or a relative is having a breakdown or is having an episode. What should people do?
Well, there's a couple of options. I would say the first thing is if there's somebody in immediate risk that you don't think you can de-escalate, you need to call 911. I mean, that's just a given. That's obvious. The other options are 988, which is a suicide hotline.
And that's fairly new.
It is fairly new. And that was one of the things that I was going to say. They do as much as they can with what they know. And that was a really big initiative on their part. And so I give them kudos for that. So 988 is a suicide crisis line that's nationwide. That is very helpful. The other thing that people may not know in Hillsborough County is that we have a mobile response unit that runs 24/7. That's a number that you can call, and a clinician and a case manager will come out into the community and assess your loved one, your neighbor, whoever it is that you're concerned about, yourself, whoever it is that you're worried about, and see if they need to be evaluated on an inpatient basis, or if they just need hand-holding to get to the next phase, which is maybe outpatient therapy or medication or whatever it is. So you have some options. I strongly feel that if people used the 988 or the mobile crisis team, that we would have a lot less tragedies.
Yes. So for everyone out there, 988 is nationwide.
Yes.
And mobile response teams, while y'all have one,
Yes.
I'm sure that community mental health centers across the country have
I
similar services.
I would hope so.
Yes.
I can speak to Florida. Most communities have one, and we have one for Hillsborough County.
And I do, and you tell me if you're wrong, the time to look into this and research this is not when the crisis happens.
No, it's now.
It's now.
Yeah. It's just like if you have, you leave your kids and you have with the babysitter, you have, this is what you do. It's the same principle. You have those at your fingertip in case something happens.
Absolutely.
Yeah.
So you mentioned our youth.
Yeah.
And social media, the cell phones, all that stuff. What could schools do better at?
Okay, I'm going to say something that's not very popular. You ready?
Well, we're all here to learn.
Okay. Cut the cell phones. Cell phones in school, no bueno. They have their use, but a kid that is so focused on their cell phone is not going to get what they need as far as not just learning, but socializing and learning social cues from their peers and learning how to work with people and navigate that kind of thing. They're just in their phone posting stuff. And that has been the biggest issue that we've seen in our child programs is kids that are isolated, comparing themselves to other kids, and cyberbullying. Those are huge.
Yeah.
It's sad, really.
It's super sad. And I think the schools are trying.
They're trying, but you got to get parents to buy into it and say, hey, yeah, we put it in a locker, lock it up. If my kid needs me, they know where to get it. But during class curriculum, that's...
Yeah, I mean, look, and we have the school shootings, all this kind of stuff, and people are like, well, they have to be able to respond. Look.
Well, the teacher has one.
Yeah, the teacher has one. The school can get a hold of you.
Yeah.
This is the big deal.
Yeah.
One of the things that I related to, because my girls have already gone through everything.
Yeah.
School, high school, college, they're out,
Right.
They're working now. But I can tell you, and I remember stories, and we didn't have this. So when we were growing up,
Mm-hmm.
there were not cell phones.
Right.
And so...
Damn, you're old.
I know. Hanging in there.
Me too.
But just with a little water moccasin and fireball.
Yeah.
But, at the end of the day, if you didn't get invited to like a really cool party,
Mm-hmm.
you didn't find out till Monday.
That's right.
When you went to school.
That's right.
And you're like, oh, you're such an asshole. You didn't invite me. Sorry, right. Blah, blah,
right.
blah. But you didn't have all weekend to get depressed.
And not everybody in the entire state or whatever didn't know about it either. It was just a small circle of people.
Just a small circle.
It wasn't every school in the county.
But now, you could have a kid staying home on a Friday or Saturday night, doesn't think anybody else is doing anything because nothing's going on. And then they see on their social media feed their friends or people they know at this party, they didn't get invited. That is brutal.
It is brutal.
And I can't even imagine as a kid when you're still insecure.
No way.
And you're trying to figure yourself out to be hit with that kind of rejection.
It's horrible.
It's so, look, technology is going to evolve.
Of course
we all know that.
Of course it is.
And there's some really good stuff with it, and there's some really bad stuff with it. But at the end of the day, we really need to focus on what's important, and that's our kids' mental health.
Couldn't agree more.
So how's technology helping? Well, we already know how it's hurting.
Yeah.
But we said there's also a good side, like there's telehealth, AI. What are some things that you think might be beneficial from a technology standpoint in the field of mental?
So I think the pros are accessibility. I mean, you can log on anywhere and really access anybody if you need to talk, probably 24/7. I think I still have to mention that one of the downsides that I didn't mention before is that when you're doing a face-to-face or a person-to-person, you can see nuances of people's behavior. You can see their facial expression. You see if they're tapping their foot and they're all anxious. You don't see that when you're doing virtual. So I think the pros is the accessibility and affordability. I think it's less expensive because you don't have an office. Somebody's doing it in their living room or whatever. AI, I think you can garner a lot of information quickly, which I think is a plus. But I also read recently about a teen who started a relationship with a chat bot and was so dependent and addicted to this woman. And when that phone was taken away from him, he died by suicide. So it can have a significant downside as well. So I think anything in moderation, use it for what you need it. But when you have a dependency on it and you start to lose yourself in it, then that's where, the line has to get drawn.
Oh, it's brutal.
Yeah.
And I know friends and family that use therapists on the phone.
Yeah.
Because they're remote or they're traveling.
Yeah.
And so it's better than nothing.
Of course.
But your point, always face-to-face, in person is always better.
Yeah.
Although I think you would agree with the shortage of therapists that it's hard. Sometimes it's 3 or 4 months. And you're like, there's an episode happening right now.
Right now, exactly.
And
right.
I cannot wait for 3 or 4 months.
That's exactly right.
So I think that there's so much that still needs to be done.
Mm-hmm.
I want everyone to know that we're going to wrap this session up, but we are going to have a part 2.
Great.
And it's going to be more around mental health parity. And that's a term that I'll share with y'all, and Roaya can give you a little bit more detail. And there's a lot going on with the new administration and what they're trying to do. And I think there's some really good things that the MAHA movement is looking at. I think there's some things that we need to assess and if they want to make changes to make sure that we do it in a thoughtful way. I'm hoping and think that they would, but we're gonna talk because that's a little bit more of a big issue that I don't want to squeeze into this. But I do want to wrap this up with, first off, thanking you.
No, you're welcome. Thanks for having me.
The work that you and your team does is God's work.
I appreciate it.
I mean, y'all are fairly underpaid. You are helping people at the worst time.
Yeah.
And you're helping people's families at the worst time. And sometimes you're the last hope. Yeah. And just, it's amazing what you do. Thanks. So thank you so much.
Yeah. Appreciate it.
I also would tell everybody out there in radio land or whatever this is.
Podcast land.
It's all about advocacy. And what I mean by advocacy, if you haven't watched previous podcasts, is it's advocating. It's standing up for something and pushing for it and making yourself be heard. If you go to the website, disruptivedialogue.org, we have got a site that allows you to join a forum, to provide feedback, to hopefully, as these build, listen to stories. We have template letters that if you want to send something to a legislator, state or federal, that you don't have to create your own letter. We already have these sample letters that you can look at, read, add your story, sign, and send. We have links that can take you to your state and federal legislators. So you don't have to research it all. It's there. So that is just a tool to try to get everybody, not just to learn about these issues, but to take action to make a difference, because you never know. It could save someone's life.
Well said.
So that being said, Roaya, thank you.
Thank you for having me.
Congrats with the new merger.
Thank you.
Very exciting. Ibis Healthcare.
You will be working twice as hard.
I'll be working twice as hard as I'm retired.
That's right.
Take care, everybody. Great talking to you again, and take care of your loved ones. See ya.